Hello everybody, my name is Omar Albtoush, an Assistant Professor of Radiology, University of Jordan. Today I will present two quick cases in musculoskeletal imaging. So here we go. The first case is a 60-year-old female patient presented with femoral fracture post falling down while walking. So this is the X-ray of the thigh that shows displaced fracture involving the proximal shaft. Do you have any more information to add or to think about? In fact, we have a very important point that this case or this patient was not presented with high energy trauma to cause such a fracture. Do you have any idea regarding the cause of such a fracture? Okay, so we can proceed. What's a quick description and most likely diagnosis? What do you think? In fact, as you can see, we have a cortical thickening. So the cortex is not thin and we don't have any underlying pathological process to cause such a fracture without high energy trauma. I mean pathological process like, for example, osseous lytic lesion and so on. So the cortex is thick and we have a medial spiking, and the cortex is thick and the location is subtrochanteric femur or the proximal shaft. All of these findings are classically seen in one entity that can predispose to fracture. This is a generalized process and can be caused by alendronate. So here an explanation for this type of injury, in fact no significant trauma, so you need to think about underlying process, either local process such as metastasis or for example focal osseous lesion, or even a generalized process which can be seen by alendronate therapy, especially for more than 5 years. So the hint here is to keep in mind the non-severe nature of trauma. So you need to ask about the mechanism of injury, and when you find things are not proper or are not going to happen with such low energy trauma, you need to think about underlying process. So here alendronate fracture, it's a femoral fragility fracture due to severe suppression of bone turnover by long use of bisphosphonate therapy. In fact, the radiologic signs, we have already mentioned the transverse or short oblique fracture line, lateral cortical thickening, and the medial sided spiking. So this is our second case for today. 61-year-old female patient presented with chronic left gluteal pain. Pelvis radiograph, frontal view was performed. Please have a look. As you can see, we have a remarkable finding of calcification inferior to the ischial tuberosity bilaterally, more pronounced on the left side. So what do you think? Do you think, for example, it's a benign or malignant process? In fact, the bilaterality is more in keeping with benign process, and this region is prone to shearing forces between the osseous structure and the adjacent soft tissue. So it's one of the areas that commonly results in bursa formation. So this is a bursa formation inferior to the ischial tuberosity, and there is no malignant potential, so no reason, for example, for biopsy. And if you are worried, for example, about its mass effect upon the adjacent structure and its true size, you can perform a cross-sectional imaging. This is another view. As you can see, it's a lobulated calcification and its an intimate relation to the ischial tuberosity. So we already mentioned that. So the diagnosis was calcified bursa formation. We already mentioned lobular calcification inferior to the ischial tuberosity. Bilaterality is important in suggesting the diagnosis, and also the localization. In fact, we already mentioned that there is no malignant potential. Thank you for your attention.